Bismillahirrahmanirrahim. Today we are talking about the neoplastic disorders of the intestine, and here I want to mention that cancers of the small intestine are comparatively rare as compared to the large intestine, which is the major site for malignant tumors. Different types of cancer may occur in the colon or large intestine, but the most common cancer that occurs in large intestine is the colonic adenocarcinoma. We know that when a malignant tumor arises from the epithelial cells, we say this is carcinoma. But when a malignant tumor arises from the glandular epithelium, we say this adenocarcinoma. So colorectal adenocarcinoma is the malignant tumor of the glandular epithelium. We know that the most inner layer of the colon, the mucosal layer, invaginates inside into the epithelial wall to form the colonic crypts, and these colonic crypts have glands, and since the adenocarcinoma arises from the glandular epithelium, so this tumor originates from the cells that line these glands. Colonic adenocarcinoma as a cause of death worldwide is second to cancer of the lung, which is the first cause of death from cancers throughout the world. The colonic adenocarcinoma is the most common cancer of the gastrointestinal tract. In the picture you can see that this is the glandular epithelium and the secretory cells which secrete mucus, and here in this crypts various cells are located. For example, the stem cells are located here, the neuroendocrine cells are located here, the peanut, which are antibacterial cells, they are located here, and the epithelial cells and goblet cells that secrete mucus, all they are located here. And the mucus secreted by these intestinal glands, it goes into the lumen of the intestines and form two layers. The outer layer is the thin layer and the inner one is the thick layer. And the presence of this mucus layer protects and prevents the bacteria in the lumen of the large intestine to come in direct contact with the lining epithelial cells. We know that a tumor is formed when there is uncontrolled cellular multiplication or uncontrolled cellular proliferation. We know that the cell division is under the tight control of the cell cycle, and the cell cycle is continually watched by various genes, and the function of these genes is to prevent the mutated cells, which is the major culprit in a tumor, to divide. There are two types of genes, tumor suppressor genes and proto-oncogenes. proto-oncogenes under a strict and regulated process allows the cell to divide. While the major function of the tumor suppressor gene is that it identifies cells with mutated DNA. And if the cell is having a mutated DNA, it is an abnormal cell, and the tumor suppressor genes will not allow these cells to divide. It will be handed over to the DNA repair genes, and if the cell is repaired, it will come back from the repair workshop to the cell cycle and it will be allowed to divide. However, cells with severe DNA damage or multiple mutations, they are forced by the DNA repair genes to undergo apoptic cell death. So, in colorectal cancer, most of the cases of colorectal cancers, they are sporadic. By sporadic we mean here, there and rare. And the sporadic mutations that occur in the cells cannot be associated with any other syndrome or disease. And therefore we know very little about these sporadic mutations that give rise to the colorectal cancer. However, the sporadic mutations and the resulting colorectal cancer doesn't occur in families, and it is not a genetic condition. On the other hand, there are some mutations that will lead to the colorectal cancer, and they are known because these genetic mutations, they are inherited from the parents to the offsprings. One important gene is the adenomatous polyposis coli gene, and this APC gene is actually a tumor suppressor gene, and the function of this APC gene is to identify mutated cells, and those mutated cells where DNA damage is beyond repair, they are forced to undergo apoptic cell death. And in this way, this APC gene normally prevents the mutated cells to divide. But when this adenomatous polyposis coli genes becomes mutated itself, it will not form its function efficiently when it is mutated, and what will happen that the cells, they are not going to undergo apoptic cell death, and these mutated cells, they will undergo uncontrolled proliferation. Initially, if only the APC gene is mutated, it will lead to an benign condition which is known as the adenoma of the colon or an adenomatous polyp. But unfortunately, this adenomatous polyp or neoplastic polyp accumulates further genetic mutations. For example, in KRAS and P53 tumor suppressor genes. So, when further genetic mutations are added, then the cells, they go completely out of order, and the result will be the adenocarcinoma of the colon, which is a malignant tumor. The second very known gene is the DNA repair genes. But this story is different from the adenomatous polyposis coli gene. Adenomatous polyposis coli gene mutations are associated with the adenomatous polyposis coli syndrome. And in this syndrome, interestingly, I want to mention that there may be 100 to 1000 polyps present in the large intestine. And if in adenomatous polyposis coli syndrome, if the large intestine is not totally removed surgically, this is 100% chance that the original adenomatous polyps, they will progress to cancer, and this is a type of evolution of the adenomatous polyp into malignancy. The DNA repair genes normally identify DNA defects, and they will try to repair and fix DNA defects. These genes give rise code for proteins that will fix DNA defects. But when these DNA repair genes themselves, if they are mutated, what will happen? That the uncontrolled cellular division will result in the formation of adenomatous polyp or neoplastic polyp. Since there is no APC gene mutation in this exercise, we call them as the hereditary non-polyposis colorectal cancer. So the two syndromes, the hereditary non-polyposis colorectal cancer or HNPCC and adenomatous polyposis coli syndrome, they are well known and they represent the inherited forms of genetic mutations that will give rise to the colorectal cancer. Now, as in our previous lectures on colorectal polyps, I mentioned that there are various types of polyps. For example, we divide them into neoplastic and non-neoplastic polyps, and the non-neoplastic polyps, in which the malignant potential is rare, and most of the time they do not give rise to malignant tumors. However, that possibility cannot be totally excluded, but as compared to the neoplastic polyps, which are adenomatous polyps, the chance of malignancy is less in inflammatory, hyperplastic, and hematomatous polyps. But these two types of polyps, adenomatous polyp and a polyp that has a structure like the tooth of a saw and their microscopic appearance, and they are known as the serrated polyps. So these two polyps, adenomatous polyps and the serrated polyps, they carry high chance of malignant transformation. And in adenomatous polyps, the problem here lies with the adenomatous polyposis coli genes. And it will give rise to, before colorectal cancer, it will give rise to the adenomatous polyposis coli syndrome. Here, under the microscope, the cells, they look normal columnar epithelial cells. But in serrated pipes, which are associated with mutations in the DNA repair, they are mostly supposed to give rise to the hereditary non-polyposis colorectal cancer, and they have the typical appearance of teeth like the asa teeth. So the serrated polyps and the adenomatous polyps, they are very prone to undergo malignant transformation. Now coming to the risk factors associated with colorectal cancer, which is the most common malignant tumor of the gastrointestinal tract. Here we think of this old man who is sitting in the washroom because he is constipated. And why he is constipated? He is taking very little or poor fiber diet. This is an old man, by that we mean he is having an advanced age. His sex is male and he is smoker. So in this picture of this old man smoking and constipated, it gives us at least 5 of the uh, risk factors. It indicates 5 risk factors, and this person is having a family history of colorectal cancers. Other members of his family, they also have suffered colorectal cancer. In addition, the persons who have history of polyps and those persons who suffer from inflammatory bowel diseases like ulcerative colitis and Crohn's disease, they are more susceptible to develop colorectal cancers and the polyposis syndromes. For example, familial adenomatous polyposis and hereditary non-polyposis colorectal cancer. These two syndromes, this familial adenomatous polyposis is associated with mutations in the polyposis, adenomatous polyposis coli gene, and they are associated with the DNA repair genes. So a person having a family history are the one who suffer from familial adenomatous polyposis and hereditary non-polyposis colorectal cancer are more prone to develop the colorectal cancer. Now, out of the risk factors for the colorectal cancer, some risk factors are such that we can modify them, and they are known as the modifiable risk factors. For example, we can advise the patient to quit smoking. We can advise the patient to stop eating red meat. We can advise the patient to add fibers to his diet, and we can advise the patient to reduce weight. But there are some risk factors known as the non-modifiable risk factors, and we can't do much to those factors. For example, we cannot change the age of a patient. And if a patient suffers from inflammatory bowel diseases like ulcerative colitis and Crohn's disease, we can't do much to them, or we can do little. Moreover, the familial adenomatous polyposis, which is carried by the mutated APC gene, and the hereditary non-polyposis colorectal cancer that happens due to mutated DNA repair genes, these are also comparatively non-modifiable factors. Now coming to the morphology of the adenocarcinoma, so the colon cancer may appear either in the form of forming a polypoid mass, like a pedunculated polyp. It will form a polypoid mass that will protrude into the lumen of the large intestine. This cancer may become ulcerated, and there can be bleeding from the ulcers. Sometimes the cancer induces a strong desmoplastic reaction. By that we mean formation of excess connective tissue, and it may narrow and potentially it can obstruct the intestinal lumen, and this type of change is known as the stenosis. Some cancers are or some lesions may take the form of infiltrative lesions, and they invade the nearby tissue and very quickly infiltrate. Two types of morphologic types of colorectal cancer are well known. However, adenocarcinoma can arise in any part of the colon. There is no area excluded. But most commonly, it takes one of the two forms. The most common form is the one that arises in the descending colon. And in this type of colonic cancer, what happens that it involves the colonic wall circumferentially all around the lumen, and they will form annular masses and known as the napkin ring, and potentially they will cause narrowing of the lumen of the large intestine and may be the cause of intestinal obstruction. In these type of cancers in the distal colon with forming a napkin ring, we see dark red blood and mucus which are mixed with stool. The patient suffers from pain, bloating, and flatulence. The other common morphological type of the cancer, which represents 20% of the colorectal cancers, it will occur in the ileocecal junction, in the cecum and right colon. And this type of lesion form a mass which grow in the form of a polyp, these polypid masses, and they will form exopitic lesions protruding into the lumen of the cecum. When these polyps become ulcerated, there is bleeding, and chronic bleeding in these patients will lead to iron deficiency anemia and weight loss. Sometimes the patients are asymptomatic and have no symptoms. Whatsoever, both these morphological forms, they penetrate the bowel wall from mucosa just to the transmural involvement of the large intestinal wall, and when they become enlarged, they can be palpated. Because as I told you that invasive tumors induce strong desmoplastic reaction. By desmoplastic reaction, we mean excessive formation of the connective tissue. So they form hard masses that can be palpated. Under the microscope, the three most common pictures that are seen, one is the typical type of adenocarcinoma. Here, the tumor cells can be identified as tall columnar epithelial cells, and these cells, glandular epithelial cells, may or may not produce symptoms, but here the elongated large glandular structures are formed due to excessive proliferation of the neoplastic cells. The second picture that is common in colonic adenocarcinoma, that sometimes the foci of squamous are neuroendocrine differentiation. The cancer cells, they will appear as squamous cells or neuroendocrine cells. And as we have mentioned in the carcinoma or adenocarcinoma of the stomach, a particular type of cells known as the signet ring cells, they will appear under the microscope. The signet ring cells are those in which the nucleus of the cell is pushed to the periphery, and it gives the appearance of a signet ring. So in one type of the cancer, we see the signet ring cells. So these two types of microscopic appearance can be identified. But there is a third very severe and aggressive type in which the cells cannot be identified, either squamous, columnar, or signet rings. And we say that these tumors are poorly differentiated and they form solid tumors without the glandular structures. No glands can be identified under the microscope, and this is the more severe and aggressive type of, or more severe and aggressive stage of the cancer. Colorectal cancer can be staged from stage 0 to stage 4. Stage 0, also known as carcinoma in situ. The cancer is limited and confined to the mucosa of the intestine. And at this time, if it is surgically removed, there are greater chances of the cure. The patient can be cured. But in stage 1, the cancer extends to the submucosa, beyond mucosa, but here again the lymph nodes are not involved. And again, surgical removal of the cancer can be beneficial, more beneficial. In stage 2, the entire wall, mucosa, submucosa, muscular layer, and serosa, they are involved. But still here, there is no lymph node involvement. And again, surgery can be, surgical removal of the affected colon may be of more benefit. But in stage 3, the lymph nodes are involved now, additionally. But in stage 3, there is no metastatic spread of the cancer to the other organs of the body. And again, here the treatment will have benefits, some benefits. In stage 4, which is known as the metastatic stage, the cancer is metastasized to the different organs of the body outside the primary tumor, and secondaries are found in other organs. The cancer has got metastasized. If the cancer happens in the colon, it mostly is metastasized into the liver. And cancers that occur in the rectum, they are mostly metastasized to the lungs. Here, the cancers become totally incurable. We can also grade the colonic or colorectal cancer into low grade or grade 1, in which the cells can be very well differentiated, and the moderate grade or grade 2, in which the cells are poorly differentiated, and the high grade or grade 3, in which the cells are totally undifferentiated. And when the cancer is in this grade, it becomes incurable. For diagnosis of the colorectal cancer, colonoscopy to visualize the cancer through a colonoscope, and during colonoscopy and sigmoidoscopy, in which the sigmoid colon is visualized and a biopsy is taken, and later on we do histopathological examination of the biopsy specimen, and this is the standard approach to the diagnosis of the colonic cancer. Additionally, we may use X-rays, computer tomography, magnetic resonance imaging of the abdomen and chest, as well as pelvis and to look for the secondaries and to determine the extent of the tumor. Blood in the stool is also important test that should be advised, because presence of blood in the stool indicates some intestinal pathology. And in colorectal cancer, mostly the ulcers, they bleed and we see blood in the stools. Very important, though not very specific, is the immunohistochemistry, in which we look for various tumor markers. And the carcinoembryonic antigen as a tumor marker is mostly asked in the exams. Though this is not very specific for colorectal cancer, but it's the presence of the marker carcinoembryonic antigen is mostly indicative of the colorectal adenocarcinoma. Cytokeratin 20 is also a protein, and it is also a tumor marker for colonic cancer. The barium enema, in which a contrast barium is given to the patient through the rectum, and then the colored or contrast barium spreads in the large intestine, we take various different x-rays. And here in this x-ray you can see that the large intestine is so much narrowed by the tumor that this narrow area, which is known as the apple core sign, and which is particularly seen in the descending colon. People who are strongly susceptible to colorectal cancer, for example those with polyps, those having family history of the familial adenomatous polyposis, or non-hereditary, non-polypotic, hereditary non-polyposis colorectal cancer, these people are screened, and at various intervals they are examined by the colonoscopy. Colonoscopic examination is done. Moreover, their stools are looked for the occult blood. And this screening is very important, because these people, they are very susceptible to the colorectal cancer, and if the cancer is diagnosed at an early stage through these screenings, it can be treated well as compared to when it is in an advanced stage. And this type of screening will give us an early detection and diagnosis of the colorectal cancer. Now, this screening through colonoscopy and examination of the fecal occult blood is particularly done in people with family history of colorectal cancer, familial adenomatous polyposis syndrome, and hereditary non-polyposis colorectal cancer. Thank you very much.